Greetings to each and every one of you, graduates, family members, faculty, and friends. I know all of us are feeling the pain of our social isolation from not being able to be physically together in the same space for this joyous moment. I join you from Durham, North Carolina, in the United States, where I have recently moved from Baltimore as I transition into semi-retirement. First of all, I want to extend my heartiest congratulations to each of you who are graduating from this extraordinary School of Public Health. You are standing at the threshold of a new stage in life, during which you will have the privilege of translating the learnings of your MPH program into your day-to-day professional life. Not only facts and tools, but perspectives and passions that have arisen during your time of study. You have been very fortunate to be able to study at one of the world's premier schools of public health that is immersed within the realities of Bangladesh and BRAC, which have made, as we all know, extraordinary progress in improving the health of its people. Secondly, I want you to know how deeply honored I am to have this privilege of sharing a few words of provocation and inspiration. I am so grateful for the opportunity that I had to live and work in Bangladesh from 1995 to 1999 and to learn firsthand about BRAC and also about all the pioneering work in public health, community-based primary health care, and social development that have made Bangladesh a beacon to low-income countries. It was during that time that I came to know many BRAC staff, most notably your first dean and the chair for our ceremony today, Dr. Mushtaq Chowdhury. In my view, Mushtaq has been one of the foremost public health champions of my generation because of his remarkable contributions to the development of BRAC as an organization and to the creation of high quality programs at BRAC that serve the needs of poor people and empower women, and for the capacity that he has had to bring the best of epidemiology and monitoring and evaluation for the benefit of large-scale practical programs that have improved the lives of millions of people. After I left Bangladesh and moved to Haiti, I nominated BRAC for an award of $1 million that the Gates Foundation was giving each year to an outstanding organization working in the field of global health. Not surprisingly, BRAC won that award in 2004, beating out 50 other nominations. I was so proud to have played a small role in making that possible. Of importance for today is the fact that funds from that award were used to help establish the School of Public Health. The principles upon which BRAC and this school have been built are so important to our world, not only for yesterday and today, but for tomorrow as well. These include, but of course aren't limited to, working in partnership with the poor, and especially with poor women, to build healthier lives for themselves, their children, and their families through practical, effective, sustainable programs to enable them to achieve healthier lives with dignity and purpose, using the best available knowledge, field experience, and technical expertise. To soak in these values as a student in an MPH program that is immersed in the reality of the community and the rich community health programs that BRAC has, I'm sure has been an enriching and ennobling and even transforming experience. In thinking about the many challenges that you and all of us face today and tomorrow, I want to focus on three interrelated themes: ending deaths from readily preventable or treatable conditions, engaging more effectively with communities as partners to help them improve their health, and three, maintaining your own moral compass. First, a few words about ending readily preventable and treatable conditions. The progress that has been made in Bangladesh and elsewhere in improving the health and well-being of impoverished people has been one of the great advances of our world over the past 50 years. James P. Grant, with the assistance of John Rhodey, was one of the leaders who inspired and led this advance through his leadership in promotion of what has been referred to as the first child survival revolution, the saving of millions of lives of children through highly effective vertical programs such as immunization, prevention and treatment of childhood diarrhea, including the promotion of homemade oral rehydration therapy, birth spacing, and other specific interventions. This was, as many have said, picking the low-hanging fruit off the tree. But the fact remains that 5.3 million children are still dying each year, almost all from readily preventable or treatable conditions. Nicholas Kristof, the masterful op-ed contributor to the New York Times newspaper, wrote a column in July of this year that he entitled "The Mistakes That Will Haunt Our Legacy." He asked the question, what will our great-grandchildren find bewildering and immoral about our own times? This is a question highly relevant to us in the United States as we find our own history of slavery and racism to be so bewildering and immoral. His answer to that question contained the following. A second area, in addition to denialism about climate change and abuse of animals in factory farms, that will leave our future generations baffled, is our heartlessness regarding the indifference to suffering in impoverished countries. More than 5 million young children will die this year and around the world from diarrhea, malnutrition, and other ailments. We let these children perish essentially because of our tribalism. They are not a priority for us. An NGO called MUSO, working in an impoverished peri-urban population of Bamako, Mali, has shown us that with frequent home visits, early detection of sick children with danger signs, and prompt treatment in the home or at a nearby clinic, under 5 mortality rates can be achieved that are the same as those enjoyed in developed countries. By my count, apart from the COVID pandemic, 25 million people will die this year from readily preventable or treatable conditions, including the children I just mentioned, as well as mothers and their offspring in the process of being born, people with HIV/AIDS, tuberculosis, and malaria, people with undiagnosed or treated hypertension and diabetes, and people without access to basic surgical care. We can and we must do better. Secondly, a few words about engagement with communities as partners to help them improve their health. In spite of all the progress that has been made in global public health, one of our major failures has been the lack of progress in engaging communities as partners in improving their health. When I was living in Bangladesh, I had the privilege of hearing Sir F.H. Abid, the founder of this great institution, give a lecture in which he said that after World War II, when the United States was the unquestioned leader of the world, the rest of the world wanted to emulate what the United States had in terms of healthcare. And that meant specialized doctors, highly trained nurses, and well-equipped hospitals. As Sir Abid told us, what the rest of the world failed to recognize was that the good health that the US had achieved at that time was in reality built on local community engagement and building a public health foundation of good nutrition, safe water and sanitation, adequate housing, and healthy household practices. The over-reliance on westernized curative medicine that emerged in developing countries after World War II spawned the 1978 International Conference on Primary Healthcare and the Declaration of Alma-Ata, which I like to refer to as the sacred scripture of global health. And James P. Grant, as executive director at that time of UNICEF, along with Halfdan Mahler as Director General of the World Health Organization, convened this conference, which was the largest international governmental conference on health that had been held up to that time. And it was the Declaration of Alma-Ata that still reminds us that people themselves are our greatest resource for addressing serious, readily preventable, and treatable conditions. Without empowered and engaged communities, we will never be able to complete the second child survival revolution of ending preventable child deaths or ending other deaths from readily preventable or treatable causes. One of my mentors, John Wyan, conceptualized public health as a three-legged stool. One leg he referred to as disease-oriented public health. The second leg is services-oriented public health. And the third leg is community-oriented public health. The goal of disease-oriented public health, of course, is the control of a disease of public health importance. And of course, the effort underway to control the COVID-19 pandemic is now the most pressing public health emergency throughout the world. The goal of services-oriented public health is to get basic and essential health services to those who need them. This is often the responsibility of governments through their ministries of health or national health services. But as we all know, NGOs and civil society make important contributions to services-oriented public health. The third leg of this stool, community-oriented public health, has its goal to work with communities to help them improve their health. All three legs are vitally important, but as my mentor liked to say, this third leg has been the weak leg of global public health. Without a strong third leg, the stool itself is a weak and unstable one, unable to fully fulfill its purpose of optimally improving the health of the public. In my view, community-oriented public health represents one of the great opportunities for the future in improving the health of the public. Learning how to work with communities to help them improve their health has been one of the great contributions that BRAC has made to Bangladesh and to the world. And the resources and skills that you have obtained in community-oriented public health will help you to be a leader in this still new frontier of public health. Without community engagement and partnerships with communities in which they themselves are motivated to take action in addressing their local health priorities, we will never be able to reach health for all. This means giving communities the skills and tools to help them understand their own local epidemiological priorities and the capacity to determine if local health programs are addressing these local priorities and actually improving the health of their local communities. Finally, a few words about your moral compass. Creating and maintaining one's professional and personal moral compass is not easy, as we are all pushed and pulled in so many different directions in a world that seems ever more confusing. I offer two suggestions to embolden your moral compass and to endeavor to follow its direction. Number one, identify persons who personify the ideals that you hold and try your best in whatever challenging circumstances you find yourself to emulate them. And number two, identify colleagues with whom you can work, who can support you as you try to follow the path to which your moral conscience is guiding you. Remember that public health is a team sport. In closing, remember that you have now become a part of our treasured tradition of pioneering community-oriented public health. You are standing on the shoulders of giants who preceded you, James P. Grant and his father, John B. Grant, who is considered by many to be the father of primary health care. F.H. Abid, Mushtaq Chowdhury, John Rhodey, and many others. Sir F.H. Abid told us that change is possible through human acts of compassion, courage, and conviction. He went on to say, "I have spent my life watching optimism triumph over despair when the light of self-belief is sparked in people." Go forth with thanksgiving for what you have received, embrace the dignity of your calling, and commit yourself to do your part to achieve health for all. Thank you so much.